There we go, amniotic fluid embolism. I'm going to update you on all that we know and think we know in 2013. And briefly, I have to make my statement that I have nothing to disclose. So what I'm going to cover today is going to be the history a little bit. And it's amazing when you look at history, what you kind of find behind the doors there. Cover the incidence and what we think it is right now, how the risk factors have switched, what the mortality numbers are like, presentation, all those sorts of things, so that when you walk out of here, hopefully you'll have a pretty decent idea of what we're thinking about when we talk about amniotic fluid embolism today. Most people credit Myers with the first case report of an amniotic fluid embolism. But actually, Matthew Bailey probably had the first description. This is a fellow who trained at Johns Hopkins, graduated medical school, and was a prolific writer and looked like he had a fabulous career ahead of him in academic medicine. And when he was about 27 years old, he witnessed this horrible death of this multiparous woman going through this tumultuous labor. And after she delivered the baby, she just collapsed and died. And he wrote about it, and it sounded an awful lot like amniotic fluid embolism. He was so traumatized by this that he quit academic medicine. And the next time he showed up, it was in a very high-profile private practice position as physician to King George. Not a bad way to go. Never wrote again. This is the last thing he wrote about. But we typically credit Myers, who in 1926 did write about the first amniotic fluid embolism that we acknowledge. Now, Myers never called it that. He just described this event that was going on. But as we started to develop the signs and symptoms of the syndrome, we went back, and it's this case report that people recall and attribute to the first amniotic fluid embolism. Steiner and Luschbaugh were Chicago-based physicians, and they were at the new Chicago Lying-In Hospital at the time. And during their tenure there, the first 24,000 deliveries, there had been 3 unexplained deaths. And when they did the autopsies on these women, what they found was this embolic-like material in the small little vessels. And right here I have, I don't know if this shows. No, it doesn't. Right here is a picture of what they likely that they saw, which is a little bit of amniotic debris here in a pulmonary vasculature. And they were the first to propose the concept that it's amniotic fluid getting into the vessels that cause this syndrome. Now, this is what's really fascinating. Based on that, they said the incidence was 1 in 8,000. To this day, people are quoting an incidence of AFE of 1 in 8,000. There is no evidence that it's that low. Or that high, I should say. No evidence that it's that high. And in fact, for the next 26,000 deliveries, there was never another case of amniotic fluid embolism. And that actually starts to push it a little bit more towards what the incidence is more likely to be, which is somewhere in the range of 1 in 16,000 deliveries or thereabouts. Over the next 8 years, you get a bunch of other case reports that come through, and then Gross and Benz in 47 report about the first aspiration from the ventricle. Now, in this particular case, this was a Jewish woman whose family did not allow an autopsy in keeping with their faith. So instead, these pathologists asked if they could aspirate some blood from her ventricle after she went through a similar event, and they allowed it. And it was at this point we first get the description of centrifuge blood showing this top layer of amniotic fluid. Going forward, it becomes more of a clinical entity as we go into the 50s and 60s. And then in 1973, Atwood and Rome proved that it's the tears in the uterus or the cervix that allow for entry. That had been theorized, but it had never been demonstrated. And it's at this point in time that it gets demonstrated. And then Resnick in 1976 does the first case report of her survival from AFE, and he said this is what it was because he used this newfangled thing called a central venous catheter, placed it, and was able to aspirate out blood that demonstrated amniotic debris. So this is the history of amniotic fluid embolism. Incidence, as I said, varies greatly. It is not 1 in 8,000, so please put that out of your mind. The pooled rate around the world is probably somewhere in the area of 1 in 15,000, and it's pretty likely, we think, that in those that survive, those may not be getting reported, but it's very hard to tell how many of those cases that occurs in. In the US, we are looking at numbers that are probably 1 in 15 to 1 in 16,000, but in Europe, they have a much lower incidence. If you pool Europe, what they're reporting is an incidence of 1 in 49 to 1 in 60,000. And in fact, it's in the UK that they are claiming the rate is as low as 1 in 60,000 cases. Now, why the discrepancy? Nobody really has a good explanation. It could be the way that we're defining it, getting it into the registries, but nobody can come up with a reason as to why it's so low in the UK as opposed to every place else. This is actually a graphic of the UK confidential inquiries. Right here, this should be rate per, where's my thing here? Rate per 100,000, not million. But what this demonstrates to you, and what I really want to make the take home, is how the incidence of amniotic fluid embolism has gone down in reporting in the UK since 1963 when they broke it out as its own entity. And right now where the UK is somewhere down here, and the US and Australia are somewhere up in here. So that's how the incidence has changed along those lines. When can an amniotic fluid embolism occur? Well, basically anytime you've got enough amniotic fluid, it can occur. And this can happen with things as simple as amniocenteses or saline abortions or D&Es, or removing a cerclage stitch can be enough to set this up. However, most of the time it's going to be around the time of delivery, either pre or intrapartum, but it can occur up to as late as 2 days later. So the question now becomes why, and that's what we're going to investigate a little bit here in a few minutes. Since the year 2000, maternal mortality for amniotic fluid as all comers, all the reasons for mortality, puts amniotic fluid embolism somewhere between 5 to 15%. It's about 5% in the UK where they have that much lower rate. The US and Australia are similar at about 13 to 14%. If a mother has what we perceive to be an embolic event, an amniotic fluid embolic event, what is her rate of mortality at the time that that occurs? That has improved tremendously. We used to say it was almost universal death, and then it dropped into 80% and went down to 60% in the 1990s. Now it appears to be as low as 22 to 24% in the US, a little bit better up in Canada. Sweden, nothing bad about the Swedes, it's just for information only, a little higher at 44%, but this is a tremendous improvement in survivability after you have this kind of event. As for the fetus, if the event occurs before delivery, outcome is poor. I'm not surprised to hear that. For those that get delivered during the event, the mortality rates range, and this has been fairly stable at 9 to 44%. If you deliver that baby in an effort to resuscitate the mom, and they survive that event, they're likely, 30 to 50% of them are likely to have some kind of neurological impairment. So that's not great. I mean, it's an improvement from past history, but it's not great. One of the reasons the fetuses do tend to survive and come in at this a low mortality rate of, say, 9% is because we're doing a better job of resuscitating mom, and if we aren't meeting resuscitation standards, getting the baby delivered. And I don't want to take away the thunder for the next speaker, but when a cardiac arrest occurs, you should go ahead and institute proper ACLS resuscitative measures. And that includes, in the pregnant patient, making sure you have left uterine displacement. And you can do this a number of ways. One of the ways that I suggest is have somebody kneel down behind her and roll them up on the top of your thighs, and that will help wedge. The other thing is literally have somebody just grab the gravid uterus and pull it up and off of her to allow for a lack of occlusion of the vena cava. If after 4 minutes you aren't getting a response, then deliver the baby. Over and done with it. Now you can go back and forth and discuss about, what about the baby? If the baby is viable, you've actually improved the outcome on the baby. Now, a baby born at 24 weeks, admittedly, is different from a baby born at 38 weeks, but you have also improved the viability to the mother. So get the baby delivered if after 4 minutes you aren't getting the response that you're looking for. Now, who's at risk? Well, the classic teaching was older multip, tumultuous labor. Pitocin didn't come in until about the mid-20th century because it wasn't something that was used. But as they were using it and identifying cases, they came through and said, oh, maybe Pitocin is also a problem. Forget all of that. None of that holds true today. No one is saying that these are the people who are at risk. And the problem we have is there is no real good way of defining who's at risk. Right now, the list seems to be a little more expansive, but depending upon who you read, more people are coming back and saying different things. So it gets very confusing when you look at the literature. We're still at the older mom, in particular the older primiparous mother. Operative deliveries, be it C-section or forceps delivery, any kind of operative delivery, any kind of uterine rupture, any kind of abnormal placental implantation, such as an accreta or previa, cervical lacerations. Prostaglandins for induction is a little bit of a hot topic. In Canada, they claim that you double your incidence of AFE if you use prostaglandins for labor. US studies say that does not hold true. So again, hard to know who is actually at risk given what the current literature says. What we think we know about the pathogenesis of AFE is that, one, fluid gets into the maternal circulation. There is a favorable pressure gradient that drives it in there, and it could be either through the cervical lacerations or the placental site or whatever. And that this then goes on to cause, whoops, I'm poking the wrong one. This then goes on to cause acute respiratory distress, hypotension, possible cardiovascular collapse. It all sounds really nice and neat. But there's a real problem with that. And that is, we know that normal women go ahead and get exposed to this, and they don't have this problem. Only a certain subset go on to develop these symptoms. Why? So the dilemma is, we know most women get exposed to amniotic fluid and they stay asymptomatic. We know that the syndrome can actually present for the first time up to 2 days after the delivery of the baby. So that's a problem. And we also know that we don't have a good animal model. And frankly, that's a problem for us too, because there's no way to study this entity. There's no way to create it and then look at how it manifests, why it manifests the way it does, and then learn how to manage it a little bit better. And we have certainly tried. We have even taken little bunny rabbits and injected them with amniotic fluid, and they just blink at us and are happy as can be. There's just nothing out there. So let's start from the beginning and look at what's in the amniotic fluid. Could it be the composition that is setting us up for this? Well, no surprise. We're going to see fetal hairs and fetal cells in that amniotic fluid. But the other thing we see are prostaglandins. And depending on where you are in the pregnancy, the prostaglandins are different. Early in pregnancy, the prostaglandin is primarily prostaglandin E. As the pregnancy develops, prostaglandin E starts to go away, and it's replaced with prostaglandin F2 alpha. Now, we all know prostaglandin F2 alpha as another entity. It's called hemabate. And we don't give that to people who are hypertensive, and we don't like to give it to asthmatics because it itself can cause hypertension and bronchospasm. This is a very vasoactive substance. Other arachidonic acid metabolites that we find in the amniotic fluid are bradykinins, leukotrienes. Leukotrienes can also cause quite a bit of vasospasm in the circulation. Endothelin, again, very active on bronchial smooth muscle and on the vasculature. All of these are making up the amniotic fluid that the woman is exposed to. Now, in terms of theories of activation, the classic theory was that this was a mechanical event, that you got so much fluid into the circulation that it would enter into the right side of the heart, it would block flow through the pulmonary vasculature, cause cor pulmonale, and then you'd have this immediate collapse. It's all very nice and neat, but that's not what happens. So we have to rethink the theory. All right, amniotic fluid releases these primary and secondary mediators. They have all this stuff in here. So what is it that is going on? So in 1984, one theory that came out was that it causes activation of the complement system. And this was supported by the finding that C3 and C4 levels would be low after a amniotic exposure. So that was kind of interesting. And it also, as we have come to learn, and this is coming primarily out of the trauma literature, is that complement activation can also initiate a coagulopathy. And we sometimes see that in amniotic fluid embolism. In 1993, though, another proposal was made that actually this material stimulates immune mediators, and this causes mast cell degranulation, such as what you see in an anaphylactic reaction. And indeed, in the early studies, what they would see is elevated tryptase levels. And so they came out with a new term for this called anaphylactoid syndrome of pregnancy and tried to explain it that way. Well, as time went by, what we discovered was that tryptase was not a stable finding. It did not signal an amniotic fluid issue. You can get mast cell degranulation and thus see the tryptase levels go off, but what you were not going to see is necessarily an amniotic fluid embolic type of thing. So over time, this is getting disregarded and rejected, and we're moving back towards the fact that this is more likely a syndrome that is caused by activation of the complement pathways, because we are consistently seeing low C3 and C4 levels in people who manifest the disease. Even if they're manifesting it lightly, we'll see a dip. So what's the proposed series of events? You have this amniotic fluid that gets into the vasculature, sets off these mediators, and this causes intense vasoconstriction and bronchoconstriction. And so you get the dyspnea, the cough, you get some of the common symptoms that you can see. You get the hypotension, hypoxia, cyanosis. These are fairly frequent, especially the hypotension and dyspnea. It goes, continued release of these inflammatory materials. Eventually, you may get activation of the coagulation pathways that takes you down the pathway of bleeding and a coagulopathy, but you also go on to arrhythmias, pulmonary edema, shock, seizures, and full-blown cardiac arrest. That's the proposed series of events there. We know, or we believe, that this is a biphasic event that we see. So initially, you get these severe increases in pulmonary pressures, this sudden pulmonary hypertension, if you will. This causes right ventricular dysfunction. That ventricle fails because you have impaired outflow from the right ventricle into the pulmonary vasculature. You get overextension of that right ventricle. You get septal deviation into the left side of the heart, and this particular phase lasts for about 30 to 60 minutes. And then you move on to phase 2, which is you get failure of the left side, and that's primarily because it can't fill to be able to pump out. So it's believed to be more of a filling problem at that point in time, and this is where you get into your biventricular failure. This is a transesophageal finding with amniotic fluid embolism, and if you look up this just came out in December of 2012, New England Journal of Medicine. But on this particular piece, they have the video for the TEE in this case, and you can see the marked marked tricuspid regurgitation that happens across here. But you can see how the right side is just ballooned up. You're pushing the intraventricular septum way into the left ventricle, Same with the intra-arterial septum way into the left atrium. And this is impacting the ability to fill the left ventricle. So it's very impressive when you actually see it. The coagulopathy that we talked about happens in anywhere from 22 to 83%. Again, very highly variable. Most people quote the 83%, but really the literature supports that we're not sure how often it actually happens. And it does not have to be a part of AFE for you to call it that kind of situation. What we believe happens is that there is tissue factor, or one theory, I'll put it this way, is that there is tissue factor in the amniotic fluid. It binds to factor 7 here, and that activates the extrinsic pathway, and this goes down and it starts this problem here. However, as we've continued to look at this, and again, this is coming a little bit too from the trauma literature, is that do we really have to have fetal procoagulants in the amniotic fluid triggering this pathway? Can it be that it's just the fact that this event is causing complement activation, and that is enough to trigger the coagulopathy that we tend to see? Also in this, as people have analyzed what's gone on, they wonder if maybe massive fibrinolysis is at the heart of this. Now, TEG studies, thromboelastography studies, don't support that concept. But if you recall Dr. Lucero's great lecture yesterday where she was talking about the differences in information that you get from TEG versus ROTEM, one of the points that she made is that you get more information out of the ROTEM. Now, I'm not promoting ROTEM at all, but what I found fascinating is that the difference in information. So just because one type of technology doesn't agree with another, maybe there's a little bit more there. This just came out in January of 2013. It is a case report by Collins. And in this case report, Collins reported that they took a woman back for urgent C-section. It was I believe it was a non-reassuring trace. It wasn't urgent. It was not an emergency. And they do the cesarean delivery, and as soon as the cesarean delivery is, the baby is delivered, then she develops cardiovascular collapse, coagulopathy ensues. Now, in the title of this, is they called it a suspected case of amniotic fluid embolism, and I don't recall that they really explained that they went through their differential and were able to disprove other possible etiologies. What was notable about this case, though, is that they used their rotational thromboelastometry for management, and they found that what was going on with the coagulopathy was a hyperfibrinolysis at the time. So what they did is they went ahead and instead of using the usual things, they used lysine analogs. And what lysine analogs do, these are your antifibrinolytics, is that they prevent the lysing of plasminogen to plasmin, which, when allowed to go forward, destroys the fibrin clot. So if you stop this step here, you maintain your clot. Some common examples are aminocaproic acid. In this particular case, they used the tranexamic acid. I know I'm not pronouncing that right. And this is how they dosed for this particular case. But this is what they found in the case report. So it was rather fascinating to read about it. So I would suggest that if you find yourself in this situation and you have supportive technology available to you, to go ahead and use it for guidance. So what are the common symptoms that you can expect to see with what we perceive to be an amniotic fluid event? Respiratory distress, cyanosis, and hypotension. Some people claim you will see that 100% of the time. I disagree, but I think they're common enough that you tend to look with it. And it's explained by much of what I've already talked about. Other signs and symptoms, and some of these can be the presenting symptom here, are things like fetal distress. In the UK, there are a number of case reports where the presenting symptom for an amniotic fluid event was fetal bradycardia. I've not seen that in the American literature, but it is common in the UK literature. Coagulopathy has been described as the presenting event as well. Transient hypertension can occur before you see the hypotension. Pulmonary edema, all these other things make sense, but These are what you can see. You won't necessarily see all of them. Bronchospasm, people talk about bronchospasm, but that's actually fairly rare, and the thought is because the bronchospasm is so severe that you don't get any kind of wheezing with it that you can hear. We talk about prodromal syndromes, or signs, and certainly this is what I've seen in the couple of cases that I thought I witnessed during a cesarean delivery. Chest pain. In my case, there was a sense of doom. I had two who looked at me and said, I don't feel right, something's going to happen, and then boom, they were out. Nausea, breathlessness, and again, when you look at these, I mean, how many times have you had a patient complain of chest pain or transient breathlessness? There really is a thought out there that it's not uncommon for someone to get a subclinical response to amniotic fluid that gets exposed into their circulation, but it doesn't go any farther, and these might be some of the things that we see. If the mother has a full-blown syndrome and she dies, it's usually due to one of three situations. One, it's a cardiac arrest and we aren't able to resuscitate her. Two, she develops a coagulopathy and we cannot resuscitate from that. Or what's also been described, they survive the initial event, they're in observation mode, nobody's paying that much attention, and then the coagulopathy recurs and she hemorrhages out. That's been well described. Or the other thing is the initial insult from the event. She survives the initial event, but so much damage to various organs that she's in ARDS and she goes on to develop multi-system organ failure. This is a diagnosis of exclusion. And this is by no means a complete list, but it shows you how expansive the differential can be in this situation. So you need to look for other causes. The incidence of amniotic fluid embolism is not common. Many of the things on this list are much more common, and you need to exclude those before you can say that you have one of these situations. But I know the tendency is when you see a patient collapse in front of you to think of this first and foremost. Be careful. How do you manage? Well, this is the duh moment. Deal with what's in front of you. Just go ahead and manage whatever you see going on at that point in time and go ahead and ask for help. Focus on the pulmonary stabilization or the cardiopulmonary stabilization, and if the airway is not intubated and she is not responsive, go ahead and get your airway intubated at this point in time. You want to oxygenate, you want to try to ventilate as best you can. If she's found unresponsive and in full arrest, start your CPR, do the usual protocol, remember your left uterine displacement, and if she's still pregnant, remember your 4-minute rule and get that baby out if you're not getting the response that you want. Now at this point, I usually get asked, what lab should I draw to try to show that this is going on? There is no conclusive lab test out there at this point in time. And if anything, what you're looking for is to draw the types of labs to help you potentially exclude. Seeing squamous cells is not going to help you. We see them all the time when you go looking for them. We can't tell if they're fetal and we can't tell if they're maternal, so that's not going to tell you anything really. Thrombocytopenia is not a common finding. Cardiac enzymes could be there for obvious reasons of cardiac enzymes, so that really doesn't point towards amniotic fluid either. There are some newer tests that are out there on the horizon. One is the zinc coproporphyrin. Now what this is a substance that's found in meconium, and this is based on very few numbers. So there's a lot more that needs to be done with this test, but they have found that if the levels of this compound is greater than 35 nanomoles per liter in maternal plasma, that is reasonably sensitive and specific for an amniotic fluid embolism. This is based on just few numbers, though. They still need to do more to study and see what this is. Elevated tryptase, we've already more or less disproved, but I always think it's a good one to get anyway because tryptase, if that's elevated, it helps get rid of some of the other possibilities on your differential list. So it doesn't hurt, and it's a test that most hospitals are able to run. The thing to remember with the tryptase is it's not going to show you anything immediately. You have to wait for about an hour for your first draw. Next draw is going to be about 4 hours later. Next draw after that is going to be about 24 hours after that. Another test that seems to be showing great promise is the sialyl-TN antigen. Now, this is a carbohydrate antigen, and most of the literature is about its presence in people with breast cancer. And when it is found in a woman with breast cancer, it does not bode well for her outcome. It's a very bad finding. However, there is this fetal variant that's found in the meconium and amniotic fluid, and they're finding that when they're able to detect it with a specific antibody and the levels are over 50 units per milliliter, it too is showing good sensitivity and specificity for an amniotic fluid embolism. But it too is based on low numbers. We still need to get more information and more studies to be able to tell if this is really where we're going. The one thing that is cropping up is the consistently decreased C3, C4 levels, and that's what's showing great promise at this point in time. Unfortunately, none of these are readily available except for the tryptase, and so there still isn't much I can tell you in terms of how to draw your labs other than to try to start thinking about ruling out other possibilities. So back to your amniotic fluid management, you're going to go ahead and deal with what's in front of you, add your lines, peripheral lines, arterial lines. While you're drawing those lines, go ahead and draw your basic blood work that you would want to get anyway. Recommend that you go for a central line for vasoactive meds for a couple of reasons. One is the meds, but the other thing too, again, supportive technology. If you wanted to see how the cardiac output was responding, that with the arterial line in place, that can help you with the using something like a minimally invasive cardiac output device, such as the Vigileo's flow track. That ArtLine and ventilation can help you with that. Consider your other supportive technologies as well. If the patient has refractory hypotension, and initially you're going to try to use some fluid resuscitation to try to refill the left side of the heart, if that's not working for you, then go ahead and use dopamine and norepinephrine. That's been shown to have be really the best first choices as you initiate your resuscitation. If you still need inotropic support, then they suggest that you move on to dobutamine or milrinone. That seems to help with lowering pressures while still maintaining the cardiac function and the blood pressure. If you're dealing with a coagulopathy, consider cryoprecipitate early on. People given cryoprecipitate early on seem to have a better outcome. And they think that perhaps it's because it's rich in fibronectin. Fibronectin supports the reticuloendothelial system in terms of getting rid of cellular debris, and that seems to be helping. Certainly wouldn't hurt, so no sense in not doing that. But whatever you do, do not give recombinant factor VII. That has been shown to have a very poor outcome. You're dealing with now microthrombotic events, and that is not the way to go. So there is nothing in the literature right now that supports the use of recombinant factor VII. So just stay away from that. Less common but reported management steps have been just about everything. Putting the woman on cardiopulmonary bypass, ECMO, giving an inhaled pulmonary vasodilator such as aerosolized prostacyclin or nitric acid. I mean, you name it, people have tried it to get people through the initial event with various responses there. So in summary, this is the entry of amniotic fluid into the maternal circulation. We suspect that this particular fluid initiates some kind of complement activation, causes cardiopulmonary collapse. Many suspect an amniotic fluid exposure as part of a continuing of other symptoms, and it may be full-blown or it may be very mild, but whenever somebody collapses, people tend to jump to it. But remember, this is a diagnosis of exclusion. Do not go to the zebra until you have eliminated the herd. The incidence is still relatively rare. 1 in 15 to 16,000 or 20,000 is what we think it is. So Of that differential list I gave you, there are a lot of other things to be pointing to and eliminating before you go to an amniotic fluid embolism. And then though improved, you still have a pretty high morbidity and mortality associated with this event. The other problem with this is all anecdotal information, all based on case reports, word of mouth. We have no case studies to draw very well from. So again, lots of problems in terms of interpreting the literature because it seems to be so highly variable. And management entails that resuscitation. So remember to get the fetus out as you're doing your resuscitation. Use supportive technology to help you deal with it. Consider cryoprecipitate early on if you're dealing with a consumption coagulopathy. Do not give factor 7. It just worsens your outcome. And even if you get her through the initial event, make sure she goes to a ICU situation. Multiple reports of stabilization of the patient initially, and then she goes on to redevelop the syndrome hours later. Thank you all very much for your kind attention.